lamotrigine does have modest antidepressant properties, and clearly our own clinical experience suggests that lamotrigine is effective. Now, there was also a recent trial that was done in Netherlands looking at bipolar depressed patients who had been taking lithium and not getting better, and half of these patients were added lamotrigine and the other half were added placebo. And what they found at the end of the 6 or 7 week trial was that more patients that got lamotrigine in conjunction with lithium got better compared with those that got placebos. So this is called the Lamlet study. So this study is suggesting that combining lamotrigine with lithium is effective in treating acute bipolar depressive symptoms. Olanzapine story, you're all familiar with it, and this study showed that olanzapine was more effective than placebo, but olanzapine plus fluvoxamine combination was not only superior to placebo, but it also was superior to olanzapine. Now, although olanzapine was better than placebo, that is olanzapine monotherapy, most of the effect that was seen in the olanzapine group was obtained based on its effect on sleep, appetite, and the tension, but not on other core depressive symptoms. So given that, how strong is an antidepressant, whether olanzapine has strong antidepressant properties is debatable on its own. What about quetiapine? Well, quetiapine has been studied in 5 different placebo-controlled trials. 4 of them used the immediate release quetiapine, and in the Bipolar XR trial, they used quetiapine slow-release formulation. So instead of showing the data from 5 different trials individually, what I've done here is that I will combine the data from 4 of these trials. And I do want to tell you that in each of these trials, quetiapine, both doses of quetiapine, that is 300 and 600 milligrams, beat placebo. So, and also when you combine the data from all those 4 trials, as you can see, quetiapine does beat placebo, both doses. And the separation from placebo occurs at as early as week 1, and it remains significant throughout the study period. And the same thing was seen with the XR as well. Now, aripiprazole, another atypical antipsychotic, we thought would work or should work for acute bipolar depression. 2 double-blind placebo-controlled trials. Here are the results of the first trial. No difference between aripiprazole and placebo. And here are the data for the second trial. You can pretty much superimpose the data for the second trial on the first trial. So basically these 2 trials are suggesting that aripiprazole monotherapy does not work. But of course, one of the problems with this trial might have been that the dose of aripiprazole that was given was perhaps larger than the dose that might be required to treat bipolar depressive symptoms. For example, more recent trials suggest that aripiprazole 5 to 7.5 milligrams is effective in augmenting antidepressants in treating depressive symptoms in unipolar patients. So perhaps those doses need to be tried before one can conclude that aripiprazole does not work for acute bipolar depression. Unfortunately, similar type of story with the ziprasidone as well. 2 trials looked at the efficacy of ziprasidone, 2 different doses in one of the trials, and a flexible dose in the second trial. And here are the response rates for the various doses of ziprasidone in the first trial and the second trial and the placebo. And as you can see, the response rates for the ziprasidone group are no different compared with the placebo. And the problem with these trials, of course, is the placebo response rates. When you see a placebo response of 50%, it would be impossible to demonstrate the superiority of any of the drugs. Because in clinical practice, we don't see half the patients with the bipolar depression getting better with no medication. Even with medications, we can't get half the patients better. So there are, of course, challenges with the trials like these, and we are trying to figure out what needs to change to design better trials. Often, one of the problems is in these sorts of clinical trials, patients with the mild depressive symptoms get in. So here is an example. In this trial, patients with a score of 28 on MADRS should have gotten in, and as you can see, there were many patients in this trial that had scores less than that got into the trial. So that may be one of the issues that one needs to address in the future. Two other medications that I want to mention before we talk about the treatment recommendations. Modafinil, which is a drug used for treatment of narcolepsy, has been used as an add-on to treatment as usual in bipolar patients, and this study showed that modafinil was more effective than placebo in treating depressive symptoms. So here are the treatment recommendations that our Canadian group came up with in our CanMat guidelines. We recommended lithium, lamotrigine, and quetiapine monotherapies as first-line treatments. We still feel that we haven't proven that antidepressants don't work when they're given in conjunction with lithium or valproate. So given some of the older data, we still think combining an SSRI or bupropion with lithium or valproate would still be an appropriate first-line option. And of course, olanzapine plus fluoxetine combination is also appropriate. So coming back to then your recommendations, the Florida treatment guidelines, I would agree that olanzapine fluoxetine combination or quetiapine monotherapy would be appropriate. In terms of the two-agent combinations, which included bupropion or SSRIs with carbamazepine, lithium, or valproate, I think lithium or valproate would be okay, but I wouldn't combine those with carbamazepine because of the drug-to-drug interactions. I would also add to level 1 lithium or lamotrigine monotherapy based on some of the older trials, some of the recent meta-analyses, and based on some of the clinical experience. Now, level 2 gets much more challenging, and previously you had their combinations of the MAOIs, SNRIs, and other antidepressants with the lithium valproate or second-generation antipsychotics. And the trouble I have with SNRIs and the MAOIs is that although they may work, they have greater propensity to switch patients into mania. So that may not be appropriate as level 2. We could certainly think about that as level 3. So I would say before you look at those, perhaps olanzapine monotherapy based on the double-blind trial would be okay, valproate monotherapy based on that meta-analysis, or combining lithium or valproate or quetiapine with something like lamotrigine, or lithium or valproate or lithium plus valproate combination, or combining quetiapine with an antidepressant would also be appropriate. Modafinil, based on the double-blind trial as an adjunct, would also be okay. And then you had their antipsychotic combined with either lamotrigine, lithium, or valproate. You had either a second generation or first generation. I will remove the first generation because first generation antipsychotics do not seem to have any antidepressant properties. So I would say here a second generation combined with an SSRI or lamotrigine would be fine, I think. And of course, if patients don't get better, then you move on to level 3, and this is where you could think about drugs such as venlafaxine or MAOIs, or even things like omega-3 fatty acids as adjunctive treatments to some of the standard treatments. So that's the bipolar depression story. Now let's move on to the maintenance treatment. We have a bunch of mood stabilizers, and then there's, of course, lamotrigine and atypical antipsychotics. Now, you're all familiar with the data for lithium, valproate, carbamazepine, and lamotrigine for maintenance treatment of bipolar disorder. So I'm going to show you the data only for the atypical antipsychotics, and then we look at how the guidelines, your guidelines should change, because here is what you have at this point in time. But let's look at what the data suggests and see what we need to change. So this is these are the data from the olanzapine trial, and basically what this study suggested was that olanzapine was more effective than placebo in preventing a depressive or manic relapse. And the study showed that the magnitude of benefit for mania or for preventing mania was greater for olanzapine than it is for preventing depression. So clearly olanzapine is effective. It prevents mania better